final presentation of the session is going to be Dr. Ken Yale, who's the VP of Clinical Solutions at Active Health Management and also has a faculty appointment at UC Irvine. Dr. Yale will be sharing the results of a 5-year study on the impact of incentives on promoting healthy behavior.
Thank you, Kevin. While I'm getting set up, let me just say that we do a lot of analytics, a lot of predictive analytics, and as you all know, that when you're doing predictive analytics and you want to develop a model, you have to really understand your data, explore the data, and before you can get started. So what I'm going to do is I'm going to be talking about our initial data exploration that we use to look at the data, figure out what it's about, and then maybe engage in a dialogue as to what our preliminary findings mean and what more we want to learn. So that's important. We are developing some of the models currently, but this shows you the initial data exploration. So just one thing I'd like to mention, and this is relevant to the talk, I heard someone say either yesterday or the day before that something like stories trump data, right? And relationships trump stories, okay? But I contend, let's get to the data first. Why? Because you need the data to find the people to develop the relationships, right? The data is very important. And in Active Health, we believe that putting clinical insights and knowledge in the hands of patients and doctors that we obtain from the data can really transform lives. These are some of the services that we provide. And our job is to find people and get actionable insights into their hands so they can actually improve their health. So a study in 2007 showed what I think we all knew, and that is healthcare has never been good at connecting with patients. So in this study, of the population who could be identified with a current condition, half of them would be able to outreach, contact, and engage for more services. And of those people who are engaged, only about 40% of those would actually participate in activities designed to improve their health. And of those, only half, 10% of the initial 100%, would actually show any improvement in outcomes. Okay? That was 2007. It has not improved much since. At Active Health, I'm glad to say that we do better, mainly because of our predictive analytics. We do motivational interviewing, and we continuously improve the ways we reach out to patients and engage them. So what I'm going to do is look at each one of these areas, because the science of incentives was created to improve the identification of people, help encourage them to engage in their own care, and also look at sustained participation and help improve outcomes. So just a few statistics that just came out last week from Buck Consulting. 90% of US-based employer-sponsored health plans currently have health risk assessment or biometric screening programs currently. 90% of employers in the United States also offer some sort of incentive in 2014, and that's up from 62% in 2010. There's a real debate of positive rewards, negative rewards, carrots and sticks. Negative rewards used to be shunned. Now they're back in vogue. And in 2014, one study showed that 34% of employers actually use those negative incentives. Carrots are still more popular. 61% of employers use some sort of cash or other reward and benefit. 27% use like an FSA or an HSA contribution, something related to their benefits. But with more than 125 employer clients, we're really interested in what works. So I looked at the research that's out there currently, a lot of the journal research, and we found out that a lot of the work that's been done currently or up to now really looks at specific behaviors of individuals in laboratory settings. What we're interested in looking at is how incentives impact population health and ultimately the return on investment in a real-life situation. To do this, we have a lot of data. We actually track 22 million patients. We have a 50 terabyte database that's growing daily. And for this particular activity, we took 200 gigabytes of data on 1.9 million persons across 25 employers over a 5-year period from 2008 to 2012. And the common thread among all of them was that at some point in that 5-year period, they all offered an incentive. The findings that we came up with include incentives really help improve completion of health risk assessments and biometric screening. We saw a 400% increase. The health assessment information significantly impacts the ability to outreach and engage people for disease management and lifestyle coaching. And that between 6 and 11 incentives seems to be the magic number. Anything below that or above that doesn't show any real improvement in engaging patients. As far as the carrot and stick are concerned, the carrot really shows there's a significant improvement in reaching out to healthy people to engage them in wellness coaching, whereas the stick seems to be more impactful for chronically ill persons to engage them in disease management services. So where are incentives incorporated in the care management process? The initial place that incentives are included happens to be in the data collection and identification phase. Now, we already get claims data, we get electronic medical record data, we get lab data, so we can identify a lot of the patients right off the bat from that information. The problem is when you have healthy people who don't see a doctor, don't have electronic medical record information. So what it turns out is that the health risk assessment tends to be the primary source of data, and that's very significant because these are people who either are healthy or think they're healthy and may have a high risk for a future condition and can't be identified except for the information that we're able to obtain through a health risk assessment or biometric screening. The second place that incentives appear is in the engagement phase, the phase where you're trying to reach out to folks. You've already identified them. You're trying to encourage them or get them to participate in some sort of lifestyle coaching or disease management service. These include initial incentives to get them to do something immediate, to sign up for a program, or long-term and sustained incentives over a long time period, for example, a monthly reduction in premium, to get them to continuously work on the activity you want them to work on. And then finally, outcomes are another place where incentives are provided. So in working with this data, we looked at a number of specific areas, a number of specific behaviors, HRA and biometric screening, incentives for the initial engagement in disease management or lifestyle coaching, incentives for sustained engagement over time in these kinds of programs, and then improvements in outcomes. The carrots and the sticks that we looked at, obviously carrots are cash, gift cards, points. The stick tended to be, a premium penalty or a premium increase. A premium, basically additional premium. In other words, you didn't get the benefit of the reduced premium or a loss of some sort of benefit. So the population that we were looking at was very large, very diverse, had a large number of incentives. And this is important because in our initial data exploration, we wanted to look for significant correlations, significant areas where we're clustering or some sense we could make out of the data. So it turns out that, the most popular incentive was to collect health risk assessment or biometric screening data. And 5 companies chose that as the exclusive and only incentive that they were going to provide. The most people had both a health risk assessment or biometric screening incentive, as well as an incentive for sustained engagement programs over time, as well as some negative incentives for non-participation. 2 companies incented all 4 types of behavior. That's the health risk assessment, biometric screening, the initial engagement, the sustained engagement, as well as improved outcomes. 3 organizations only used a stick, basically a negative sanction if you didn't participate. 3 other companies used a penalty, but then some positive incentives along the way. 2 of the companies incented the outcomes, but no other specific activity, no other behavior. 3 companies used a cash-only benefit, and 3 others used the benefit related to, an incentive related to the benefit. Let's get into some of the results. So this looks at the impact of incentives on data collection and identification. It's a little bit busy, but I wanted to put it all in one place to kind of show you how complicated the data is and how we're trying to sort through it and find some correlations. If you look at the top left, for disease management identification, again, these are folks who have some sort of condition currently, and they need some sort of more intense program to help them improve their health. We already have electronic medical records for them, or claims data and lab data, and so we can identify who they are. So with that as a baseline, that's the 1.0. If you add completion of a health risk assessment, we are able to identify more people who need that particular kind of service. Below that, folks who are healthy and we're looking at for lifestyle coaching, we probably don't have any data on them at all. These are healthy people, haven't been to the doctor, think they're well. So basically, they don't even show up on the radar. And then they complete a health risk assessment, and all of a sudden we have a dramatic increase in identifying them because they show certain risks that we want to be able to address. So there's a dramatic increase, and then when it's incented, that's the right-hand side, we actually get another increase. Interestingly enough, in the data, when we then had an incentive for those folks needing disease management on the top right, we didn't get an improvement. And we're not sure why that is. It may be because we've already identified them through claims data and electronic medical and lab data. So they're already identified. So the addition of an incentive to complete a health risk assessment doesn't give us any more improvement in finding a risk that has to be addressed for disease management. So the impact of incentives on engagement was quite interesting. On the left-hand side, you see, again, the folks that were identified for disease management services, and on the right-hand side, people who are identified for some sort of wellness program. Turns out that if you add an incentive, a carrot, a positive incentive for the folks with disease management, you get about a 4-fold increase in identifying them for additional disease management services. But if you use a stick, you get a much larger increase. On the right-hand side, and it doesn't really show that well, HRA carrot biometric, HRA or stick, HRA or biometric carrot, the 10% shows those folks who were identified with a health risk assessment. Okay, we started with that as a baseline. Because if you start with no health risk assessment, no biometric screening, it goes down to near 0. So if you start with the folks you've already identified, you add a carrot, you get a marginal increase in the number of people who you can identify for lifestyle coaching. But if you add a stick incentive, you actually get a decrease. So we're not quite sure why that is. We're going to explore that much more thoroughly. That's very important. But it seems to be that maybe healthy people don't like penalties. Or perhaps the fear factor on the left-hand side for chronically ill persons allows them or makes them respond better to a stick. We thought this was a significant finding, and we're doing actually doing some deeper analytics into that. Okay, so the impact of incentives on outcomes. Interestingly enough, incentives specifically targeted to outcomes only improved the outcomes by about 1%. That's the very top there. Sticks, however, negative incentives overall, seem to improve the ability to improve outcomes by 8.4%. And then incenting sustained engagement was an additional 2.6%. The conclusion we drew here is that really, if you combine penalties with incenting long-term sustained engagement, we seem to see 11% increase. Now, why that's relevant, especially nowadays, is that a lot of these pay-for-performance programs and other programs are really focusing on those outcomes And so if you can get an 11% increase, that's pretty substantial. So last couple of things I'm going to talk about because I'm running out of time, and I'm the last person to stand between you and lunch, and that's a very tenuous position, so I'm going to move it along pretty quick. We looked at lifestyle risk identification, and without incentives, we can identify about 1.5 new risks per person. With outcomes incentives, we saw an increase in the ability to identify new risks, but with sustained engagement incentives, a decrease in the identification of new risks. Again, we're trying to figure out what this means. Perhaps folks who have sustained engagement incentives are working on their health, and therefore have, a reduced number of risks. I don't know. Maybe the folks who have a long-term sustained engagement incentive, like a reduction in premium every month, maybe they think the premium reduction is more important, and so they're underreporting. I don't know what's going on there, but that's another very interesting conclusion. So, and then finally, how many incentive choices are enough? With 25 organizations that have incentives, we had a wide range of numbers, kinds, different types, and so we're very much interested in how many incentives are optimal. And so took a look at the data. Data showed that when you increase the incentive options, incentive options are important because behavioral economics tells us that to have a successful program, you need to have options. You need to have more than one incentive. So when we increased it to 6 to 11 incentives, we seem to see an uptick, but anything beyond that, there showed no improvement at all. It goes back down to 1. So we also calculated potential savings from incentives, and I can get into the specifics behind this. But let me just say that conclusions we drew were that incentives are important to encourage people to provide the data you need to help improve their health care. The type of incentive, or actually the status of the individual, makes a difference. People with chronic conditions seem to respond better to penalties. And then incenting sustained engagement overall seems to have a larger improvement on a number of different parameters. So I made it under my 15 minutes. You guys will get your lunch. Let me know if you have any questions. Yes. Good question. Question is, do we consider weight management under wellness or under disease management? And it depends. If the person has a really serious problem or a comorbidity associated with weight management, it falls under disease management. If it's more of your BMI is wrong, and my BMI is wrong because I work out too much, and so muscle mass is heavier than fat, and so I'm supposed to be losing weight. I don't know why, but in that case, it's more of the lifestyle coaching. So it can be both. Yes. Differentiate between extrinsic and intrinsic incentives. These are all extrinsic. Yeah, these are all extrinsic that are offered by an organization to incent the people who they provide health benefits to. So we didn't really look at the intrinsic motivators. That would be very interesting to actually compare the extrinsic versus the intrinsic. I think having run these programs in different lives, and before Active Health, I was helped grow 2 disease management companies, which we sold, and before that I had a small startup, which we sold. I've run programs all across the United States, and I think what's more interesting is to find out demographically the different motivations geographically, because I was working on a population in New Orleans, and their psychosocial behavior and intrinsic motivations are totally different from Seattle. Now that's stating the obvious, but that has a huge implication. And so, if you're treating someone here or there, you'd like to know that, and because it's a different approach. But along with those questions, I welcome everyone here to get in touch with any of your questions. We're still mining this data. We have other areas that we're already looking into with the data. And we have a lot of data. I mean, Fred Trotter yesterday said, we don't have enough patient data. We have tons of patient data. The problem is it's not public. Fred made that qualification. But we love to mine the data and find new things. I'm sorry, you had a question? Changes in response between 2008 and 2012, so longitudinally, we haven't looked at that. I think it's a great idea because you would think intuitively there would be some changes, yeah. And the other part of the problem is, and you saw, the 25 different organizations, some of them offered incentives at different points in time. So when we try and do a case control study, we have some temporal issues that we have to deal with. So we're trying to sort through that as well. Once you start narrowing it down, you get a much smaller and smaller group that you can actually work with. So the validity then, you have to question. Yes, there was a question up here. Anything else? All right. Thank you very much for your time.